All right. Well, let's kind of jump in here in our last 26 minutes and try to go look at some software doing some practical applications of data. Here's a little bit more about using the PRO system to sort of build data capture. Now, have you know that this is sort of a slide I think about last month about sort of some of the new places, some of the places where we've captured PRO data. You can see that one of the things that I've most been surprised is the uptake by our social workers. You get to the 1970 clinic and you initially have a visit with social workers, and they've developed a series of questions. And these questions all result into a form. So, a new client fills this out, and, 10 minutes later, the social workers get a sheet that basically says homeless or housing status, food security, history of incarceration, and all of these things. And are they depressed? Are they using substances? And they saw all these referrals and all of these things that happen before they ever see a provider in the clinic. So again, it's just the use of patient-reported outcomes to really drive clinical care and get people to where they need to be more quickly. And we've used it to do signs and symptoms forms. We use it for in our palliative care clinic. And certainly a lot of other clinics that we've had before. And pediatric neurosurgery has started. I think they're in there. I think they have a little bit less than 20 now. But I think you have to ask questions is if what you're doing is ready for patient-reported outcomes practice, you can go through these slides to think about it. I think let's not go through those things right now. But once you've agreed to do that, you've sort of said, you figured out your goal. We do a lot of study recruitment off patient-reported outcomes. When people fill these forms and patients go off in a study and are sort of coming to see that patient, then really freeing up a lot of our study personnel from having to sit there and hover in the clinic or look at every patient on a case-to-case basis. So we've actually been able to leverage this technology to really help study recruitment as well, in addition to clinical care and its subsequent research use. If you're going to do this, you got to understand your clinic workflow. The solution in our clinic with this flow is in no means the solution for your setting. You've got to think about your setting and find a way to do it there. Initially, this is sort of our viral hepatitis clinic, and they wanted a fairly sequential list of instruments. They wanted everybody to be checked for depression, anxiety, alcohol, substance use, quality of life, and fatigue every visit. Those are the things that are important to them. They selected their instruments around that. And pretty much the only questions we had to deal with them were, what's the selection of your instruments, what's their sequence, and how often do you want someone to see it? The way our software is set up, you come in and you might say, you know what, I want to check for substance abuse every visit, but I want to check quality of life every other visit. That's fine. We sort of put this one every 3 months, this one every 6 months, and they just, whenever you do your survey, it's transparent to you, but the patient will get a shorter or longer survey depending on the frequency that you've set for each one of those domain instruments to be captured. When we worked with our palliative care clinic, they asked us to do some interesting things. They wanted to start with a general symptom survey. And depending on the symptoms, they wanted to know if a symptom was worse, they wanted one of those subsequent instruments, pain, anxiety, quality of life, and depression, they wanted those instruments in there if that symptom had gotten worse. But the other thing that was interesting was if the instrument had improved, they didn't necessarily want to ask it. But if the instrument was stable, then they wanted to ask it as well. So we had to put all of this internal logic where depending on your performance in your first measure, that's how we would select subsequent measures. Not simply frequencies in time, but basically put in that internal logic. And then they also wanted alerts for depression and for pain severity. They wanted to really know when things were a lot worse to make sure that they paid attention to it. Again, sort of really highlighting what was a big problem for them that day. So you say you have improved pain, all of a sudden you jump down to just anxiety. And if you are depressed, then you can do suicidal ideation. We also use intimate partner violence with our social workers in the clinic, which is something we had no insight into. But it's very interesting that now we know if there's intimate partner violence, and we have a response system in the clinic that functions independently of the clinicians to take care of that eventuality. In the pediatric clinic, they sort of had an interesting thing for us to think about. There was one PRO session, but it actually was for 2 users. So it was a guide of caregiver and child. So the caregiver begins, and the caregiver is asked some questions, and basically if the caregiver wants to participate, they answer those questions. If they want to and are able to participate, they'll answer a couple of questions, and they'll do this family impact module, which I think is very interesting. It's some challenges that you guys have had in pediatrics that we don't necessarily think about a lot in adult medicine. But the illness of the child really has repercussions throughout the family. So it's almost like you want to measure, get a little bit of insight into not just how the child is doing, but how are the parents doing, and how is this impacting their ability to provide care. So you have to keep them both healthy to keep that child healthy. Yes, so caregiver would do part of it. They get to the family impact module, and then they would be asked, hey, can your child fill this out independently? And if the child can do it, they're given the time that they finish out. If they can't do it, the parent indicates that, and then asks the questions of the child and fills the information in. So we get to know, with that one session, we actually capture data from 2 users. I think we're going into asthma next month and subsequently musculoskeletal. This is just a diagram of the workflow at the 1917 clinic, and we really analyze workflow, finding what we call pockets of wait time. So the patients wait after they check in. Then they're triaged, then they wait in the clinic. Then they're seen by a fellow or nurse practitioner, then they wait again while that case is discussed with the attending physician, who then comes and discusses the case. And then there's another pocket of wait time in the lab. But we felt that we wanted 12 minutes and that we could have enough. These 3 pockets of time were about usually 20 minutes. So within that, we could comfortably get 12 minutes of patient-reported outcomes done. And you have to think about your clinic and think about your practice if you're going to put in software like this and understand that you might be a tablet computer on the wall clinic, or you might be a hand a tablet to everybody, and they can just kind of carry it from point to point. It really depends on your workflow. But if you don't get workflow right, you fail. We failed in 2004. We built software with all the instruments you can imagine that took an hour and a half to complete one session, and we put 1 kiosk in our waiting room. So pretty much we ground clinic flow to a halt. And though we spent around a year developing that software, our clinic director came out and unplugged it 2 hours into his life and threw it on the ground and stopped it. And I could not say PRO was a 4-letter word for about 3 years until we figured this out. So let me tell you, you can build pretty software, but if you don't get your workflow right, you ain't going anywhere. Again, you've seen some of these pictures of how we do this. This is how we monitor the completion percentage. And interesting insights that came from the part of it. People like this, where they don't complete and 20 minutes go by, 25 minutes go by, we actually send someone in to ask them. And often we'll hear something like, gosh, I forgot my glasses today. Oh, that's okay, let me read it for you. But after you've forgotten your glasses 2 or 3 visits in a row, then we begin to get some insights into literacy that we never had before. And then we can ask questions like, well, wait a second. If you can't read, I'm handing you 8 prescriptions every month. Maybe that's why you're not being compliant, and I can't get your disease under control. And again, an indirect benefit of this stuff is that you find out more things about your patient that you knew before. Here's an example of sort of how the summary of the data looked. We can look at this very quickly, see it over time, and just kind of make treatment decisions. I love to look at this and see what's going on. I don't have to go in and talk to this person about, are you using marijuana? I go in there and I say, wow, you've been using marijuana. Let's talk about whether that's a good idea or a bad idea, or behavior we need to change or not, depending if you're in Colorado. Yeah. So you can ask that. Here's a sort of, when we started looking at this concept of what's in your diagnosis list and what do patients actually report, look at the overlap in terms of substance abuse. On the chart, these many people in the blue circle actually had substance abuse that was denoted as current in the chart because it was an active diagnosis. But you can see the much smaller universe of patients in green who actually did self-report substance abuse and the small overlap of those 2 populations. I think this is the reality across a lot of these sensitive domains in our electronic medical record, which is a static thing that sits there between visit to visit. Whereas if you can get data for patients, you're getting data that's more accurate and more timely. And you can see how prior, patients will tell you a lot more about prior. This is sort of how, when I said I wouldn't take that diagnosis off your list until at least 2 years, and every one of my colleagues has a different time horizon to do that in. And when we looked at things that predict adherence to medications, it really looked like the data that we captured from patient-reported outcomes did a lot better job of correlating with the literature that's out there on the factors that predict adherence than the data from just the chart and the problem list. So it's an interesting study, but it really gives you an idea how, again, you expand your innovation space, you get something like patient-reported outcomes data in there, You can start redoing a lot of the studies that you've done before, and you find out all of these interesting insights into, with these new data types, I probably am getting different insights into my population. So that's patient-reported outcomes captured within the healthcare setting, but much more exciting is how do you capture data outside of the healthcare setting, and how do you get to knock on people's doors between hospital visits and get some data? And let me tell you sort of two things that we've been working on. The first one, I guess, is for the people that maybe don't have what we think of as on one side of the digital divide, where they maybe don't have access or the fast facility to use technology as some other folks. So we basically partnered with Andrea Charrington in preventive medicine, and we developed some software for her. And the question was, if I'm in a diabetic clinic and I figure out that some people are doing very poorly in the management of their diabetes, can I pair them with a community healthcare worker who's a diabetic too, who's doing well with their care, and can they teach them some things and motivate them and help them set some self-care goals for them to go forward? And again, here, the community healthcare workers were on with the technology. So you didn't expect, this works with a lot of economically disadvantaged populations and people who don't necessarily have access to continuous internet access or smartphones, but basically we call them and we speak to them and we go through this questionnaire, and the community healthcare worker records all the information there. They encourage them, they get a bunch of demographic information, they encourage them to set a goal. This individual has set a goal that they want to walk and be active. They're going to get a call once a week according to this protocol, and they're going to be said, have you walk those 15 minutes every day? They've sort of set a limit of how long they want to walk every day, and then you collect that information. And basically, if the person is doing really, really well, that person then is encouraged to take on another goal. And this way, it isn't just you're in the clinic and you say, hey, I need you to do better at exercising and diet. Now you actually have someone that's a patient like you who's calling you, motivating you, and talking to you about getting those goals that you set yourself accomplished, and telling you how they beat the odds to achieve those goals themselves. So it's a very different way to provide care, and certainly this is a small study, it's a pilot study, but we actually saw a lot of goals being completed, and we saw a lot of people saying a lot of good things about this approach, and it's an approach that we're going to try out in a broader scale in some other conditions. And again, it's expanding our innovation space to get outside of the clinic and capture data in the community. This is some of our test data. And basically, this is what you'd see as a community healthcare worker. You'd log in, you'd see your specific work list, and you would see which forms are kind of due. When they're overdue, the flag turns to red. You can send messages between community healthcare workers and the clinic, and this is sort of someone's diagram of their goals. They can actually print this out and share it with the clinic, and someone in the clinic always knows who referred them, can always look in and see how people are doing in their goals. So when you get that patient, the next time they're in clinic, you don't ask, hey, how have you been doing with diet and exercise? Oh, I've been doing okay, I'm walking 20 minutes a week. No. I have a graph of exactly what you did in the 6 weeks I haven't seen you in, and whether you hit those metrics on every week. And I can talk around this data and congratulate you and encourage you and sort of find a way to get you to meet those goals more reliably.
Was it difficult to get IRB approval to make that kind of connection between patients?
No.
It is no problem.
Traditional protocol, no problem. You can see that this sort of surprised me. I've worked with interactive voice response systems before, and you're ecstatic about a response rate of like 5 to 10%. These are like the calls you get all the time on your phone that they say, hey, you just won a cruise ship, or whatever. I immediately hang up on those. But we got through almost 50% of the time, which is ludicrous that people would, but it's more difficult. Hey, how you doing? This is James. How are you today? I just wanted to check up on you. It's harder to hang up when it's someone like that. And because of that, I think a lot more conversations occur. 125 goals were set. People were followed up for 12 weeks. The walking goal and the carb counting goal were the ones that was more commonly used. And these are some, this is just some qualitative data on some focus groups of the community healthcare workers subsequently. And, how do they feel? They feel that they really are an extra step to help them manage their diabetes, and that's how they talk to patients about. There was also a lot of unscheduled contact with the community healthcare workers. And in many times, there was issues that developed with transportation, appointments that they didn't really know were that day, and they were able to sort of intervene and talk that patient, lead them through some options to get them to the clinic that day. So there was all these unintended interactions with the healthcare system that happened that we didn't anticipate would happen. There was a lot of messaging from patients that we didn't know. A person went to the ER with a high blood sugar. They really liked the work list of community healthcare workers because it let them know exactly what they need to do every day. These are people that really had no prior experience with technology. And one of the things that was really interesting was that patients would ask them questions sometimes that they didn't know the answer to. But they messaged the dietitian in the clinic immediately, who was sort of the person who referred them initially. And if she knew the answer, she'd answer it, or she'd get the answer from a provider in the clinic and send an answer back just in an hour or two. And then they'd tell the patient what the answer was. And the patient sort of said, wow, you really do care, which is sort of surprising to me because that's kind of the whole point of providing diabetes clinic. But to think that people were recognizing this sort of for the first time was an interesting thought.
Who are these community health workers?
They are patients with diabetes that are for the most part taken care of in the same clinic, and you are assigned based on geographic location. So they're sort of these.
It's like a Weight Watchers coach that you have somebody in the group.
I guess
Okay.
Peer mentor.
Yeah, a peer mentor is a good way to think about it.
So were they volunteering their time?
For this project, I believe that there was a small stipend, but you could probably get 20 of these people for the price of a dietitian or a nurse or something like that, because it's very little of their time, and there's a lot of internal motivation to help other people here too. So with a very small stipend, a lot of the stuff was done. This was a very small pilot project with about 100 patients, and it was amazing to me just how into it people were.
Did they have to go through HIPAA screening? I mean, they're dealing with some kind of patient information.
Usual IRB training.
That's it.
Usual type of things, HIPAA training. So it really was minimally disruptive IRB-wise, from what I could detect. It was sort of went right through standard channels. There was nothing special about it. It was approved, and on it went. I don't think community healthcare workers and peer mentors are entirely different, are things that they're used like in cancer and a lot of things. I think our IRB has a lot of experience with this type of model. The innovation here is that the peer mentor uses the technology to track and collect all this data that we can then analyze and see how people are doing between visits. But also you're bringing technology to people who don't traditionally have access to it through this community healthcare worker model, and you're asking people to self-select the goal, which is very interesting because now they're doing things that they want to do, that they're motivated to do. It's not me in clinic saying you need to do A, B, and C. It's them saying, out of these goals, I want to do that one. That's where I want to put my energy. And then sort of getting the reinforcement of I'm meeting this goal and I'm feeling better. I think there's a lot there that we need to explore. And I think, it's data capture outside of traditional settings through technology, expanding that innovation space, giving us more to work with, allowing us to provide better care, do better research, or do different research.
So those people they don't have to be UAV employees.
They're not at all.
They're just
Were they monitoring the treatment at all as to how compliant they?
One of the goals, I think there were several of the goals that dealt with that. One of them dealt with, I want to check my blood sugar 3 times a day. And there was another goal about I want to be compliant with my medicines. There was another goal about I'm counting calories. So there was a lot of aspects of their care that people could self-select into. One of the things that I think is very interesting about it is we talk about population health and population science. We've got to get out of the hospital. Okay, we're not going to sit in the hospital and solve this problem. In fact, they're not going to pay us for seeing people in the hospital. They're going to pay us for getting people in the community and preventing them getting sick and coming to the hospital. So population health is many things. A simple way that I find to think about it is a financial model. And the financial model is that the incentives are to prevent hospitalizations and bad events. And in the population health world, if we think that just the data we capture during your hospital visit is going to help you prevent readmission, I think that's not necessarily true. I need to be able to monitor you and get some windows into your life and what's going on so I can do a lot more preventive care, because I'm pretty good. When you come into the hospital and you have an acute medical issue, we got you. We can handle that. But this other stuff is going to require new types of data capture, and I think there's a whole series of opportunities here. Whatever type of research you do, you got to step out of the hospital and start thinking of ways to capture data out of there. AR power, I like to think of it as the other side of the digital divide. This is more for the people with access to technology. And this is a PCORI project. The PI is Jeff Curtis and Seth Ginsberg from Creaky Joints. And this is interesting. This Creaky Joints organization is an organization made by people with rheumatoid arthritis and psoriasis, and they basically, it's a community, and they give each other support, and they have blogs, and they have message boards, and they have a Twitter account, and they really do a lot to try to uplift people with these illnesses and kind of get through some of the tough challenges that these rheumatologic conditions entail. So that's a picture of the Creaky Joints website. PCORI has funded this project, and it's a patient-powered research network where you have to get a research institution and a group of a community around patients to work together to really create tools to promote research. And we've worked on software that really has these 4 pillars to its development. The first is to provide access to education and strengthen the community, health tracking, patient reporting, and a research platform. This is how we provide access and education and strengthen the community. We bring in content from the Creaky Joints website to this app, where you can have all the bloggers here. You have the information there. All the blog posts are put up there. It's amazing to read these blog posts. I mean, these are people living with this condition. Let me tell you, I found that there's a marked difference between treating people with a condition and knowing the physiology and the pathophysiology of that condition, and actually hearing from people how this impacts my day-to-day life is a window that I hadn't really had before. And I've read some of these things, and it sort of surprises me how maybe superficial my insight into the daily life of someone struggling with these conditions actually is. The Twitter feed that they have really talks about ongoing new issues with rheumatoid arthritis. It keeps the community abreast of the latest developments, whether they're legislative developments or new medications. They sort of have an ongoing discussion. We provide health tracking. When you see in the bottom, these 4 icons, health tracking for your results, research opportunities, and you can monitor your treatment. So you're asked, how do I feel or what do I think? We can use PROMIS instruments, patient-reported outcomes measurement information systems, a bunch of computer adaptive tested and psychometrically validated instruments to capture information from the patient across several domains. We can have other patient-reported outcomes, like the software that we put at the 1917 clinic and in other clinics, to just maybe something that's not a PROMIS instrument, but you want to capture a PHQ-9 for depression. We can go ahead and put that in for you. And there's something called Live Survey, which is similar to SurveyMonkey, where we can just ask you questions. And, you know, like, there might be a new legislation today restricting access to biologic agents. We want to ask the community what they feel about that and get their voice about that. We might just set up a quick survey with some multiple choice questions about where are you on this issue. That's not a validated instrument. There's not a lot of psychometrics or mathematics beyond that. It's just, tell me what you think about this. So we can sort of reach folks with any one of these 3. In the PROMIS instruments and the patient-reported outcomes instruments, they do them sequentially in an interval of time that's been defined by us or them to sort of track their health. This is sort of what one of them looks like. This is a physical function one. And then over time, these are all the domains where you've answered questions, and you can select any one of those domains and see sort of how you've been doing over time. Again, highly motivated people with access to technology that are going to go ahead and do this. You can also do personal reporting, where you capture information on, with the information you've captured, you can choose to email it to anyone you want. You can email this to your doctor and say, hey, let's open this up and let's look at this together. This is sort of how I've been doing. Ideally, I'd love to plug this into the electronic medical record, and there's a lot of ongoing work in that area. In terms of a research opportunity, imagine we have the concept of cohorts. If you enroll into this, we're going to have what we call an all-inclusive cohort that everybody's going to have to do. And we've chosen like fatigue, depression, quality of life, about 5 instruments that we want you to do at least once every 3 months. That's kind of minimal data capture that we want you to do. You'll also be shown new research opportunities. And now I want you to think of your studies. You have a study that wants to reach a portion of this population. You get it IRB approved, we put it in here. We put it up in Opportunity Center. Someone sees it and they say, we can target, right? We can say, this is only to go to women on methotrexate of reproductive age. Maybe that's what we want to do. It's the population we want to reach. We can make sure that this only shows up on their screens. And they basically say, hey, there's a research opportunity because we don't know enough about this. Please consider participating. Now, I'm not enrolling. It's different. I have the opportunity as a patient to fight back against my disease by contributing to research. And the whole point is that this is built by patients for patients. Every design decision I make, I sit with a patient governor group and I tell them, This is what I want to do. This is the feature set that I want to build. What do you think, or what feature should I be building? And it really is community participatory design. And all of a sudden, the software begins to take the shape that the community wants it to take because it's there to serve that community. A very different model, because every other piece of software I've ever been asked to do, I designed it, we build it, and it's out there. And it was, in large part, the idea within the team. This is different. I'm actually talking to the target audience, and I'm using their feedback to make better software that actually meets their needs. It seems so simple. It seems like what I should have been doing all along, but it is so revelatory to actually have to do it this way and realize how you can really sort of help people with these things. There's been some focus groups about this as well, and I think, you know, we found that people don't have as many concerns about data security, that as many as we have. People would love to communicate with providers outside of their clinics, and about half the patients says they're very likely to use these tools. So anyway, an interesting thing was that we saw that around 50, all these patients had an average of rheumatoid arthritis for about 11 years, and just about 90% of them reported that they never talked with anybody else with rheumatoid arthritis before we got them into that focus group. And that just to me seems insane. How can you have a chronic condition like this for 10 years and you never get to speak with someone who knows it, who's been through it with you? In the case of your children with CMV, someone who's already worked with a child with that condition, what kind of advice can they give a parent that's starting out? We need to do better at this. But again, I think this gets at one half of the digital divide, people who are highly motivated and have access to technology, things like what we build for the community healthcare workers, those folks are different. Those folks we can give the benefits of technology through a different approach. And I think it's important, both of these two strategies are going to be a big part of population health, but we need to find a way to bring the benefits of this technology and data capture between clinic visits to patients. There's a lot of biosensor talk in terms of what can I use to capture data from you. We keep looking at things like a 6-minute walk test where your phone would tell you where you, or a 20-meter walk test where you sort of walk around and see how long it took you to do 20 meters. We look at things at a sit-to-stand test, how many times you can sit to stand a minute, and can we capture that off your phone sensors? And there's, you know, sort of Health Kit and Research Kit are ideas from Apple, are ideas that we're going to integrate into this. Here's some other biosensors where you actually wear something and it tells you information about you. I like the fork and the belt. The fork, if you're eating too fast, it'll start shaking to slow you down. And the belt will relax if it's lunchtime. But when it feels like you've eaten enough, it'll tighten up because it's motorized. And if you've been sitting too long, the belt starts buzzing, which is to say, get up out of this chair, you sedentary person, go walk. So the biosensor stuff, I think, is going to be a very interesting part of our practice with quantified cell movement, and I think there's a lot of opportunity if you think of creative ways to add this to your innovation space to reach your patients and get data that other people don't have to push your research forward. I think, where are we doing? Oh, pretty much. Okay. Well, let's stop there. I think those are two examples of sort of getting using data to sort of expand what you do with the people you take care of.
So people have your hand out so they can read ahead. And if you have specific questions, I'm sure Dr. Willig will be glad to give you feedback.
Anyway, data. Think about your data.
Great. Thank you. So how do you, so the whole issue of if patients like their doctors, they don't want to tell them things that they might upset them. Are there reliable ways to figure out if the self-reported information is cleaner that way? And how do you take on an approach to that? And how much do you as the physician trust what you're being told? And
You know,
like you don't have to
I will see
follow up on it.
You know, it's not universally accurate. There's a lot of research that across sensitive domains, people are a little bit more forthright with because they don't feel judged. But it's not perfect either.
Yeah.
So a lot of
there's a great opportunity to figure some of these questions out over time. Oh, that's
But it's just, I see it as I can look at your heart with an EKG, with an echocardiogram, with a